Now we are going to talk about an important topic called cataract. It's very important from your entrance exam point of view. Before talking about cataract, let's examine about lens. Lens is a biconvex transparent crystalline structure which divides the eye into anterior and posterior segment. So then there comes the next question. What separates anterior chamber and posterior chamber? It is the iris. So the lens is placed in a saucer shaped depression called patella fossa. So now we will talk about the difference between subluxation and dislocation. So subluxation is the lens is outside its normal area and it is within the patella fossa, that is a part of which is in the pupillary axis, whereas in dislocation the entire lens is out of the patella fossa. So this patella fossa is very important. Next comes the refractive index. It is 1.386. It's approximately 1.386, which is between 1.38 to 1.4. That's because of the refractive index increases as we age. So refractive index is not constant. So the lens is made up of the lens capsule. Lens capsule is the outermost layer. It's transparent membrane. It covers the lens. It is thickest at the pre-equatorial region, whereas thinnest at the posterior pole. That is why posterior capsular rupture happens, because it's very thin there. And then comes the nucleus. Inside the lens there is a nucleus, and then inside between the capsule and the nucleus there is the cortex. So coming to the antioxidants in lens, antioxidants are glutathione, superoxide dismutase, catalase, vitamin C and vitamin E. So the three vitamins which which has the antioxidant properties are vitamin A, C and E. So C and E is present here, whereas A, instead of A you think glutathione, superoxide dismutase and catalase are present. So this prevents the lens from becoming cataractous. So coming to the first part, which is the congenital cataract. Congenital cataract occurs in about 3 in 10,000 live births. 2/3 are bilateral and it's autosomal dominant inheritance. So associated metabolic disorders include galactosemia, Loeys disease, Fabry's disease, monocytosis, hypo and pseudo hypoparathyroidism, and hypo and hyperglycemia, torch infections. Okay, we will talk about a little bit of these later. And coming to congenital cataract types, that is different morphological varieties, the most common type of congenital cataract, and it has no visual disturbance, is blue dot cataract. As you can see here, this is the blue dot cataract. It might sound dangerous, but it is nothing. I have seen many patients with blue dot cataract and the patient has very good vision. So no visual disturbance, and it's most common congenital cataract. Whereas zonular or lamellar cataract is the most common type of congenital cataract associated with diminished vision. So the hypocalcemia is the most common cause. Hypocalcemia in pregnancy is the most common cause. Okay, so the problem is the zone of fetal nucleus is usually affected and causes zonular or lamellar cataract. And then comes the nuclear cataract, which is, it affects the embryonic nucleus, and the rubella is the most common cause in nuclear cataract. Then comes the coronary cataract, anterior polar cataract, posterior polar cataract. So blue dot cataract and zonular cataract are the most important in this congenital cataract morphological types. Then comes our most important senile age related cataract. It is very common, and of that we are going to discuss about subcapsular cataract. Subcapsular cataract, it's the most common is posterior subcapsular cataract. It lies just in front of the posterior capsule. That is why it's called subcapsular cataract. It contains vacuoles which are swollen migratory lens epithelial cells, LECs we call it, otherwise called as bladder cells or Wedel cells. So these small vacuole like type things that is seen, that is posterior subcapsular cataract, and this is seen in posterior capsular opacification on the back of the lens after placing intraocular lens. Okay, the same lens epithelial cells, migratory lens epithelial cells, comes and causes this type of cataract. It is age related. So important points, key points about this type of cataract is that since it's local in location, posterior subcapsular cataract often have a particularly profound effect on vision. We have seen many patients with a little bit of posterior subcapsular cataract and they will have diminished vision. So unlike a cortical cataract in which there is a wedge shaped opacity somewhere in the border, that doesn't affect their vision. And the patients are particularly troubled when they approach headlights of the oncoming cars. like when they walk in the road at night, that's when a flash of light happens, they'll get glare. The reason is that the posterior subcapsular cataract happens on the posterior subcapsule, and meiosis is an important problem that can cause even more troublesome glare or even more troublesome vision defect, that's due to meiosis. So in the case of headlights coming, you will have meiosis, and in case of near visual activity like reading books or something, you will have accommodation reflex, and because of which the pupil will get myosed, and because of which the patient will have profound loss of vision. So lights, which is basically headlights, or glare from bright sunlight, which causes meiosis, or the patient is reading, which causes accommodation reflex, and there will be meiosis. These are the causes of decreased vision in case of subcapsular cataract. So the patient typically comes with complaints of when they are going in road and suddenly a flash of light comes, they'll have difficulty in seeing the light, or they'll have difficulty on reading because near vision affects the subcapsular cataract. So next comes the nuclear sclerotic cataract, which is a very common cataract. It is basically exaggeration of the normal aging change due to conversion of soluble crystalline to insoluble crystalloids. Okay, often associated with myopia. Okay, the cause is because of the nuclear cataract, there will be increased refractive index, because of which the rays of light will focus in front of the retina, causing myopia. And the patient usually the patient will have second sight, they call it. That is because of presbyopia, the patient will be seeing things a little far ahead because their accommodation is affected. But later on, what happens is they will get second sight. That is, the patient can see near vision because the accommodation is increased because of the refractive index of the nucleus. So that is one important point. The patient is suddenly able to see clearly. The patient is normally having a decreased vision and suddenly able to see clearly, something like a second sight in an aged. Okay, if they ask you such kind of question, the answer is nuclear sclerotic cataract. Nuclear sclerotic cataract is characterized by yellowish hue due to deposition of urochrome pigment, and it can appear brown to black. Any grades like nuclear sclerosis 1, 2, 3, 4, 5 grades are there. It could be anything. Then comes the cortical cataract. The cortical cataract, the main mechanism of formation of cortical cataract is decreased proteins and amino acids and increased sodium, leading to hydration of the lens. So there are two types, cuneiform and cupuliform. This one is the cuneiform type, wherein there is the cortical opacity is seen in the peripheral portion of the lens, crystalline lens, often initially in the infranasal quadrant. In dim light, when the pupils dilate, the patient will have glare. That is because the periphery is the problem here. So during dilatation, what happens is the peripheral vision is also affected. The peripheral vision is also clearly seen, and there will be more light coming in and leading to glare. So that is the point about cuneiform cataract or cortical cataract. And then the cupuliform cataract, it's almost like a subcapsular cataract, but the thing is it's in the cortex. So there is a cup-shaped opacity in the posterior cortex. Just below the capsule in the center of the visual axis, something like posterior subcapsular cataract. Just to have a name, we have it as cupuliform cataract. So they don't ask you much about cupuliform cataract, but posterior subcapsular cataract is one that is very important. And in nuclear cataract, what happens is there will be meiosis, there will be myopia. That's why it's second sight, and whereas in cortical cataract there will be hypermetropia. The same principle. The refractive index of the periphery of the lens will increase and leading to decreased refractive index of the whole lens. Now coming to an important topic from an UG point of view, cataract maturity. So immature cataract in which there is partial opaque lens, the patient will have an iris shadow, which you would have known in your UG exams. They'll ask you that question. The iris shadow is seen in immature cataract, whereas in mature cataract there will be absence of iris shadow in a torchlight examination, and there will be pearly white appearance of cataract. Okay, so if not operated, it progresses to hypermature cataract. We will see it now. So opaque lens, pearly white appearance with absence of iris shadow, it's mature cataract. This is mature cataract, and here there is exotropia, which is due to the cataract. Because of the cataract, the patient is not able to see, and the patient gets exotropia because of long-standing cataract. And coming to hypermature sclerotic cataract, in this cataract the Lens is shrunken and wrinkled. Anterior capsule is seen due to leakage of water out of the lens and predisposes to subluxation of lens. I used to give it as a how I'll teach students is that the in protein energy malnutrition there are two types, marasmus and kwashiorkor. This sclerotic cataract is kind of like marasmic, so it will be shrunken, wrinkled, and subluxation is possible because of the wrinkling and everything. The lens will be pushed on one side. Whereas the next one, this is Morgagnian cataract. This is hypermature cataract in which liquefaction of the cortex is there and the nucleus sinks on that. As you can see, this is the nucleus sinking. So Morgagnian cataract is like a kind of kwashiorkor cataract, kwashiorkor type of protein energy malnutrition. Just an analogy. And then coming to the liquefied cortex, it leaks through the intact capsule and blocks the trabecular meshwork. This leads to phacolytic glaucoma, that is lysis of the lens particles, and it goes and attaches to the trabecular meshwork. Our lens protein glaucoma, it's all the same. And phacoanaphylactic uveitis, that is because the lens goes and attaches to the trabecular meshwork, there will be an allergic reaction, anaphylactic reaction for the lens proteins, and that will lead to uveitis. That's called phacoanaphylactic uveitis. So these are the terms which you should know: phacolytic glaucoma and phacoanaphylactic uveitis. All these things. Coming to intumescent cataract, this means a swollen cataract due to excessive hydration. The swollen lens pushes the iris forward, leading to closure of the angle. This is called phacomorphic glaucoma. As you can see, the lens pushes the iris forward, and because of which there will be angle closure, and then that is what is for phacomorphic glaucoma. The morphology of the lens is big, that causes pushing of the lens and the iris, and that causes angle closure. Now coming to traumatic cataract, trauma is the most common cause of unilateral cataract in young individuals. So if there is an individual with a young individual with an unilateral cataract, the most common cause is trauma. And I used to ask patients if they have cataract on one side and they are a young patient, the most common history which we ask is trauma. So blunt trauma may cause characteristic flower-shaped opacity called rosette cataract. As you can see, this looks like a rose, and due to the impact of the trauma, the iris diaphragm moves backwards and touches the lens capsule, which gives an imprint such as iris pigment imprint, which will be like a ring, which is called Vossius ring, which you should know. And coming to penetrating trauma, penetrating injuries as a result of direct injury to the lens, it usually causes anterior subcapsular cataract or anterior polar cataract. Whereas the infrared radiation, as in case of glass blowers, there will be true exfoliation of the anterior lens capsule. So if you call something as true exfoliation, then there is something called pseudo exfoliation. Pseudo exfoliation is a condition which causes glaucoma. It looks similar to this, but it's nothing related to this. Okay, so that's why it's called pseudo exfoliation. And electric shock, ionizing radiation, all these things causes cataract. So cataracts in systemic diseases, these are very important from MCQ point of view. Christmas tree cataract is seen in myotopic dystrophy, myotonic dystrophy, and this is what is Christmas tree. And atopic dermatitis, okay, shield-like dense anterior subcapsular plaque, which is shield-like cataract. Okay, atopic dermatitis causes shield-like cataract, whereas vernal keratoconjunctivitis causes shield-like ulcer in the cornea. Okay, those two differences you should know. Whereas coming to metabolic disorders, diabetes mellitus, hyperglycemia is reflected in high level of glucose in the aqueous humor, which diffuses into the lens. Here, glucose is metabolized into sorbitol, which accumulates in the lens, resulting in secondary osmotic hydration, overhydration. Because of lens hydration, there will be change in refractive index of the lens. Obviously, when the lens swells up, there will be a change in the refractive index. Classic diabetic cataract consists of slow fake cortical opacities. If you see, there will be tiny slow fake kind of thing. That is what is diabetes mellitus causes in cataract. Next is the galactosemia. It's an autosomal recessive condition characterized by impairment of galactose utilization caused by absence of galactose 1 phosphate uridyl transferase. So what happens is, if you don't withhold galactose, then the patient will have severe systemic complication leading to death. And this is the classical picture, oil droplet lens opacity, and it is reversible. So if you stop galactose intake, you are saved from death. If you stop galactose intake, the lens will be changed back to the original condition. That is why it's called reversible cataract. This is an important from an MCQ point of view. Wilson's disease, hepatolenticular degeneration, abnormal deposition of copper in tissues. This is due to deficiency of ceruloplasmin, the major copper carrying protein, blood protein. What happens is there will be a presentation will be liver disease, basal ganglia dysfunction, and psychiatric disturbances. There will be Kasier-Fleischer ring, consists of brownish yellow zone of copper dusting seen in the peripheral descendants membrane, and it disappears with penicillin therapy. So this is seen in slit lamp. There will be deposition of the peripheral descendants membrane. The Kasier-Fleischer ring has a direct relation to the neurological features of Wilson's disease. So it's very important, and you should remember, we should not confuse with Fleischer's ring. Fleischer's ring is seen in the case of keratoconus, whereas Kaiser-Fleischer's ring is seen in case of Wilson's disease. The Fleischer's ring is nothing but iron deposition because of the conical shape of the cornea, whereas here it's a brownish yellow zone of copper deposition seen on the descendants membrane. Okay, so you have to compare and contrast those two things, and this is the typical characteristic sunflower cataract which is seen in Wilson's disease, anterior capsular sunflower cataract. Lewis syndrome, these are X-linked recessive disorder, inborn errors of amino acid metabolism with neuromuscular, renal and other manifestation. Cataract is seen. So the most important MCQ point of view is cataract and posterior lenticonus with microspherophakia. Here you can see the posterior lenticonus. This is the lens, and here there is a lenticonus here, the cone shaped posterior capsule, posterior part of the lens. So coming to the next one, which is metabolic disorders. Nothing but Fabry's disease. It causes wedge or spoke shaped posterior cataract, also known as Fabry cataract, and hypocalcemia, spokes or riders in the lens. Toxic cataract, there are different types of toxicity which can cause cataract, like corticosteroid use, particularly systemic route of administration, any type, steroids in any type, drops, inhalation, anything can cause cataract, whereas systemic route is more common, and typical morphology is posterior subcapsular cataract. And then chloroquine causes star-shaped or stellate cataract. Myotics can cause anterior subcapsular cataract. Maybe the meiosis will cause a touch of the capsule on the iris, causing anterior subcapsular cataract. Amiodarone causes anterior subcapsular cataract. A for A, remember that. And then INH, ethambutol, and smoking can cause toxic cataract. So then the important thing is secondary complicated cataract. Secondary cataracts are nothing but there will be primary ocular disease causing secondary cataract. It's usually posterior subcapsular cataract, and typical breadcrumb appearance or polychromatic cluster. Here you can see polychromatic clusters. Okay, and these are the four different categories that can happen: chronic anterior uveitis, acute congestive angle closure glaucoma, acute congestive angle closure glaucoma, high myopia, and hereditary fundus dystrophy. So uveitis, glaucoma, refractive error, that is myopia, and retinal pathology such as hereditary fundus dystrophy. So all the systems are involved here, and this is what is glaucoma flecken. Glaucoma flecken, which is basically anterior subcapsular cataract due to acute congestive angle closure glaucoma. So the clinical features will be gradual plainness, decrease in vision. We will be enumerating about gradual plainness, gradual painful, sudden painless, sudden painful decrease in vision. That is very important for you to know. We will talk about that in a separate topic. And glare and colored halos will be present. Colored halos are typically present in the case of mucopurulent conjunctivitis or acute angle closure glaucoma. And to differentiate those two, we do that Fmge's test, which is basically a stenopic slit is held in the front of the eye. The halos due to cataract will break, whereas the halos due to glaucoma will remain intact. I remember it as glaucoma glue, so it will be remaining intact, whereas the cataract, it breaks open, it breaks away. And then the last thing is monocular diplopia. In the case of intumescent cataract, there will be monocular diplopia. These are clinical features of a cataract. Then the management of cataract will deal with it in a separate topic. So hence we have done with the first part of the cataract. We'll discuss about the other part in the future classes.